serious military docs. What are some interesting differences between military and civilian medicine? Story 1. The patient population tends to be much younger and healthier. The flip side is that they tend to be much more reckless, so self-destructive behavior like smoking and engaging in risk-taking activities is rampant. There also tend to be either massive overutilizers or underutilizers of healthcare. The overutilizers go in for minor aches and pains because there's no copay and it will get them out of work or certain aspects of their duties they find undesirable. The underutilizers are the young men and women who try and tough things out or fear consequences if they seek medical care, so they tend to avoid docs. Another huge aspect of military medicine is the career implications you can impose on someone as a doctor. In civilian practice, there's little issue of giving someone a diagnosis. However, putting certain diagnoses in a service member's record can be a career killer. Imagine being in 17 years, 3 years from retirement. Then some doc puts fibromyalgia in your chart, and now all of a sudden you're being looked at for medical separation. Story 2. When you find a person who you need to help, according to military medicine, you check for massive bleedings first. But in civilian medicine, we check for clear airways first, because in the civilian life, the chances for having something down your throat is more likely than being shot and bleeding out. Story 3. Army surgeons in early days of Iraq got quoted in NYT saying major diff between military and civilian patients is the troops are in perfect health up until the moment they're injured in combat. It make for easy, almost textbook perfect surgeries. Nobody has other chronic problems that would complicate matters. Other thing they mentioned was that if they requested medical equipment, it was flown in 24 to 36 hours later. No questions asked. They'd never seen operating rooms with so much redundant equipment. All of it state-of-the-art. No need to delay for a few hours a medical procedure until a facility or piece of equipment was available. Story 4. There is no confidentiality, or rather, it is very limited. If a patient tells you they used drugs or did something against regulations that impacts performance, you're obligated to report it. But it's more than that. I haven't been on a military base for some time, but back in the day, it was common for people to check the online scheduling system via CHCS to see which coworkers had appointments with certain doctors. Unlike Epic, there was no record kept of these searches, so what would happen is a boss or clique at work would treat a person differently all of a sudden, and it would be a sign that they checked CHCS. It's not fair, but in the military being active duty and seeing a shrink is not viewed compassionately. It led to a lot of resentment to us in the mental health clinics, which I can totally understand. We were trying to help. But even stepping foot in our office would endanger their career. To be fair, administration would do what they could, but ultimately changing the culture and the computer programs takes a lot of time and effort. Story 5. I was a combat medic who did urgent care after the Army. The biggest change to me was demographic. Treating solely athletic young males can make you blind to signs, symptoms, and treatments that might be dangerous to people of more variant in age. One example is you can cause neurological damage to an older person if you infuse them too quickly with and force something to sow with hypotonicity and damaging myelin, which can be reduced in the elderly, or that smaller people are more prone to air embolism from a quick and dirty four that would be harmless to a soldier. Medics are trained mostly to stop bleeding and trauma, but you also pick up plenty of non-emergent stuff along the way working for PAS and physicians. Most procedural stuff I got yelled at for doing wrong. When I first moved to clinical from military, I later found out from a former EMT. Now physician wasn't wrong, but more commonly seen by EMTs. Do hire a former medic though, because they are very versatile and usually can handle not only EMT, clinical, and lab-based work, but also the logistical stuff like supply management, because in the military, all of those jobs are filled with medic. Oh, except receptionist. Didn't know about how medical insurance worked when I first got out. Edit. Oh, and you'll never hear a former combat medic refer to a restricting band as a tourniquet. Story 6. Medics learn a lot of stuff on the job that they would never be allowed to do on civilian streets. Suturing, injections, etc. in Vietnam era and rotated through several hospitals in Germany. Doctors were happy to teach. Oh, and I helped with several deliveries. Story 7. It depends on if you are in garrison on base in your home country or deployed. In garrison, medical procedures are rather complementary to civilian counterparts. It is when you're deployed that you have a more carte blanche method of medicine. I was a 20-year-old corpsman doing chest tubes and pericardiocentesis. Tyudikavoc on Marines and civilians in Iraq with no doctor supervision. However, in those cases, it is purely about stabilizing the patients so they can make it to the next level echelon of care. Edit to clarify, I was trained on these procedures. I wasn't just around with patients for the of it. Story 8. My dad was stationed in Texas for his military service as an orthopedic. He said every now and then someone from the special forces would come in, presumably from South America somewhere, and he would drop everything to do surgery on them first. There would be no paperwork whatsoever, and then the person would be shipped back out. Also, military doctors receive a lot more respect than civilian docs. Story 9. My dad knew a dentist in the military who said it was boring, as it was all young, healthy men who had already had any major problems fixed, so he just ended up doing a lot of fillings. He quit the military when he could do more interesting civilian cases. Edit to all those with different experiences. The guy was in the UK military, which is a country typically has good teeth. Story 10. This is way more common. Dump it in a massive bleeding wound to stop the blood loss. Hurts like, then medevac ASAP, let the surgeons deal with the rest, something you'd never see EMTs using if not in a combat area. Story 11. Sick, got the shits, throwing up, dehydrated and shaky. Hey, raise some Motrin and a light-duty chit. Get back to work, son. Military sick, got the shits, throwing up, dehydrated and shaky. Here's some antibiotics and 4 to replenish fluids and a day in the hospital. Civilian, both scenarios have happened to me. The first one on multiple occasions. Story 12. Traditionally, military dentists can work voodoo magic with amalgam for dental work. In the civilian world, we just use resin composite, the tooth-colored stuff, with a bonding agent. The reason I say voodoo is that amalgam silver fillings don't actually bond to anything. It's held in with physical friction and structure. You have to drill the tooth a certain way to make sure it doesn't fall out, and I've seen some work on veterans that are over 20 years old, and I have no idea how they made it stay in place in the first place. Story 13. I'm a civilian EMT. But in the National Guard, I'm an MP. In Army Basic, they teach every private, regardless of their MOS, how to do interventions like the needle chest decompression, something myself and my colleagues are unable to legally do in the civilian world until we are at least paramedic level. Story 14. Former Army medic, current anesthesiologist. I guess my biggest contribution here could be talking about airways here. I had 2 airways in Iraq as an undertrained medic. First one was during a complex ambush in which a guy had most of the right side of his face ripped off, including his lips, and split his tongue in half. The best I could do in that situation was, as I seated him in the back of the Humvee, getting him out of there, to place his head against the seat in front of him and let the blood run out his mouth. No real medicine. Just trying to get him out of there and be clever at the same time. Second, I was a bit more prepared. We had a gunshot wound GSW to the head on an Iraqi. He had bit his tongue off. I had a cricothyrotomy kid made a lesson I learned from airway number 1 above, and I placed that on top of a Humvee as we sped out of Sadr City. I have pictures to prove that, because as the guy taking the picture said, that was the coolest thing he ever saw. It was dangerous and no plan B. If I was called now to do either of these airways today, I would have a difficult airway card in the room, a fiber optic camera, a glide scope, a McGrath, a Macintosh laryngoscope, a host of intubating stylets and tubes, and I would inform my surgical colleagues on the need for a surgical airway. Quick lesson for those that might be reading this that can learn from my mistakes. The anatomy when doing a cric is important. The trachea branches about 3 centimeters past the cricoid cartilage. During 2, I did not know that, and I certainly main stemmed him with the endotracheal tube, ETT. Insert the tube just past the cuff and inflate, making sure to secure it, because you only have a couple cm before you lose it. Also, there could be aberrant thyroid artery branches running over your landmarks that will bleed like stink. Hope this helps. Story 15. Your priority in a combat zone for triage is to figure out who can still shoot. When you place someone with trauma to their lower limbs on a litter, leave their arms unrestricted. Just because your legs don't work doesn't mean you can't fire lead down range. Story 16. I used to be a doc before transitioning to a civilian urgent care. What acceptable levels of clean are? When I got trained on IVs, the doc teaching me literally held it in his mouth while situating everything. Gloves are a good part of medicine too, but it's more of a suggestion in the military. Also, the amount of expired meds we carry around is ridiculous. We very rarely get new stuff, and so you're supposed to make it last. In our defense, though, needles don't really get less sharp with age, but still. Story 17. I think the biggest difference is that in military medicine, people will come in for the smallest things, stuff that they could handle on their own with just a little common sense. And every time we say something about it, it's always the same response. Why would I pay for it? I'm only any nothing. I don't have money to spend on meds. Listen, buddy, if you can't buy 4 worth of Dayquil, you seriously need to reevaluate your budget. Story 18. Medics also have a few specialties. I was an Army medic orthopedic specialist. The scope of practice and experience is dependent on how knowledgeable and competent the surgeons feel you are. On deployment, it was essentially no holds bar as far as what procedures we were allowed to do, a benefit to no insurance or liability. This included actual surgery on wounded and routine cases on active duty military personnel. Yes, that is cutting and suturing under the watch of the surgeons. It is a little hard for me to remember, but as other people have stated, we were definitely doing things that would only be done by a physician in states. You can have immense responsibility as E5 sergeant if you are up for the task. That includes being responsible for ordering and fitting millions of dollars of equipment, striker, deroil, casting supplies, etc. You could be the casting clinical supervisor, and when the orthopedic clinic supervisor goes on leave, you're in charge of that as well. Other responsibilities can include key custodian, MSDS book, making sure everything is sanitary, CAHO compliance, etc. Basically jobs that will be done by multiple people in the civilian world done by one soldier. You can also side train and work with prosthetics, physical therapy, and occupational therapy to ensure the continuity of care. The surgeons I worked with in the military were great, including hospitals and clinics in Germany, Walter Reed, and Brooke Army Medical Center. On a side note, the VA care I get is amazing. Story 19 ID also like to add a few more items since I was a civilian doctor first who joined the military later because reasons. I'm active duty doctor at a frequently deploying unit. 1. In the military you get paid about 15 of what you're worth if you're board certified, or less. No Joe 2. The military is one of the last remaining organizations where malignant personalities imagine being screamed at unnecessarily a lot by commanders who need your input, but are mad that your medical determination isn't what they wanted to hear, but think berating you will change your medical opinion for some reason are not just allowed, but encouraged. Those malignant personalities decide your fate in terms of promotion and can make your life a living whenever they feel like it, and do so at the drop of a hat. 3. You answer to non-medical people. So people who think your job consists of handing out ibuprofen decide what your value is to the organization. C2, for the military EMR, is awful. It consists of HLTA and a DOS-based yes. That DOS CHCS for order entry, yep, 2 separate systems for data retrieval and order entry that communicate as often as they feel like it. Supposedly, they're changing it in a slow rollout over the next 5 years. 5. Unlike civilian organizations, the military sees no reason to make sure that your credentials or skills stay up to date. The less up to date you are, the less likely you are to leave the military to take advantage of one. They see certifications and training for providers as an inconvenience, which means a lot of military providers could be behind, sometimes what feels like decades behind in terms of either standard of care or delivering high-quality care. 6. You deploy, which increases the amount of 2 and 3. 7. Your patients are all knuckleheads and hilarious. See other comments about the underutilizers and risk-takers who aren't used to getting good care or anyone giving about them. So they tend to be very grateful. They're easy to care for. Think college kids who instead of going to class work on large military vehicles and lift weights and get into even more booze and shenanigans. 8. By Army regulations, commanders have the right to know certain things about your care, the type of condition, your deployability now, and in the future, medications or treatments that might interfere with your ability to do your job. There are regulations that clearly outline what they are and are not entitled to know. However, they think they're entitled to all medical information. If you refuse to give them what they aren't entitled to, 2 and 3 just get worse. Most docs would just give them what they want to make their own lives easier. Screw confidentiality. Those of us with any HIPAA integrity suffer. There are probably more things. Coming from my civilian training, I have to say 0-10, do not recommend, would not repeat, edit forgot to add the HIPAA stuff. Story 20, I work in an inpatient ward on a military base. Coming into the Air Force, I had no idea we even had those. I take care of older veterans, I wipe butts, help feed, bathe, and dress them. I sometimes forget I'm even in the military since I only wear scrubs. Sometimes we get younger active duty patients, but they are usually there to recover from surgery. In the Air Force, all of the enlisted medical technicians are EMT certified, yet they can work anywhere from a ward, ER, clinic, or front desk. Story 21, I could do whatever was deemed necessary to a military personnel. Civilian side, I had a license, and I could get it revoked, fined, or possibly even go to prison if I perform an intervention that was not on my license. Even if it worked, also military is HABC. Edit, for example, do needs an NCD or a CRIC to bad. Unless I get someone who is qualified on the phone to put their license on the sacrificial altar, I can't do those things even though I was taught how, because it was not covered under my civilian license. Story 22, my dad was an ophthalmologist in the Air Force. He mentioned how there was a big difference between the civilian practice and military, mostly the culture of it all. It was Dar, last name, not major last name. As a military doc, you're normally treated like a civilian more than any other officer, and you get big bonuses for retention. Story 23, attention. Serious tag notice jokes. Puns and off-topic comments are not permitted in any comment, parent or child. Parent comments that aren't from the target group will be removed, along with their child replies. Report comments that violate these rules. Posts that have few relevant answers within the first hour and posts that are not appropriate for the serious tag will be removed. Consider doing an AMA request instead. Thanks for your cooperation and enjoy the discussion. I am a bot, and this action was performed automatically. Please contact the moderators of this subreddit message compose or AskReddit if you have any questions or concerns. Story 24 Motrin and water cures everything in the U.S. Army. Headache, drink water, take Motrin. Sick, drink lots of water, take Motrin. Twisted your ankle, hey, race a bunch of Motrin. Now go drink some water. Gunshot wound, apply Motrin directly to GSW, and then pour water on top. Story 25 Army BH provider here. Having worked both in and out of the active duty hospital setting and field environment, and done internships in the civilian world, the biggest difference I'd say is accountability for quality of care. In my opinion, in the civilian world, because of how insurance works, your doctor has financial incentive to want you to like them. You're a consumer, you can theoretically take your money elsewhere. In the military, you get what you get. Don't like me, too bad. File an ICE complaint to make yourself feel better. Unless I break the law or provide some type of unethical treatment, neither me nor my civilian counterparts are going anywhere, other than the fact that I truly give about my patients. I have zero motivation to provide anything outside of the bare minimum of standard of care. I want to do right by you. You're the reason I come to work every day. Your hurt drives me to be better, to do better. And one day, between meeting my Army obligations and additional duties, on top of the sheer number of patients I see in a day, and the administrative bullshit and sheer amount of time I spend writing an 18-page note in your medical record, I might burn out. And I hope to God that at that moment, I have the insight to see that I'm starting to fail you, and I do us both a favor and drop my refrad packet, or maybe I won't notice, and it'll become that typical Army provider y'all are angry at having to come see, that pushes pills and says see you next month, and you file that ICE complaint that no one will actually give about. Story 26, as some people have stated, a major difference is that certain diagnoses can change your entire career. However, I personally never saw anyone's career ended by diagnosis. I saw many people unable to get a proper diagnosis because it would end their career. I worked on a submarine, and the nuclear weapons personnel and nuclear engineering personnel had some of the most strict medical requirements in the military. Additionally, their communities were all critically undermanned fleet-wide. The only treatment any of them ever received for anything not life-threatening was megadoses of ibuprofen. Fractures, second-degree burns, torn ligaments, a panoply of dermatological problems. Hey, race a bucket of ibuprofen. Non-nuclear personnel with the same problems would receive much more thorough treatment, and civilians with the same problems would receive much more thorough treatment. Story 27, as a purveyor of military medical services for the last 18 years, and counting, I can say almost for sure that military doctors care more about ensuring you can deploy than they do your actual health. I literally have to lie my off symptom-wise to get anything more than Motrin, and to take a few days off from doing that thing that bothers you speech. I could have cancer or who knows what else. I will never know unless I see actual doctors. Story 28, this probably won't even get seen, but for a patient standpoint, one difference I know of firsthand is military docs pick and choose what they want their patient to know. I took my husband to Womack ER while he was still active duty because he thought he was having a heart attack. We find out it's a really bad anxiety attack after he gets an EKG and nothing is physically wrong with him. Fast forward 3 to 4 years, and I'm going through his medical documents after he's been discharged because he's now in heart failure, and I find the EKG from that ER visit clearly listed as the 2 heart diseases he's recently been diagnosed with by a civilian doctor. My husband's heart failure and even possibly his open heart surgery could have been avoided if the Army docs had told him what was going on and didn't put his body through so much physical and emotion stress that his heart couldn't handle. He's now 100 disabled and doesn't trust doctors at all. Story 29, I'm super late, but this thread is incomplete until it includes you Army Ortho's story. Teaser, alright, say you're in the middle of goat screw Afghanistan and you command a forward surgical team. That's 4 surgeons, 3 real surgeons and a knuckle-dragging orthopod. You got a total of 20 people in your unit. 2 are beds for ER beds, for ICU beds, and the capacity to hold on to a patient for 24 hours at the most, and you're in a tent in Afghanistan, usually under rocket attack. You get a call on the radio that an IED just took out a dismounted patrol, and you've got 6 critically injured patients coming in, and they'll all be there in 7 minutes. Your goal is not how can I get this patient back into the fight. Your goal is, how can I get this patient stable enough to survive the 30-minute Blackhawk flight from my FST to Bagram? Where there's a real hospital, this changes everything. Story 30, hands down, biggest difference is the freedom. Obligatory, not a doctor, but a medic. When I was a medic, it was very well known that I wanted to be a doctor. I was doing college at night and busting mine the clinic I worked in. I made that clinic mine and learned everything about it. My docs and PAs saw that diligence and gave me more and more freedom in treatment. By the end of my career, I was regularly doing clinical procedures on my own, had my own patient load that I did the entire care plan for, and was presenting patients in the same vein a medical school student would be. Docs from other units would regularly drop by and mention how impressed they were with my care, etc., etc. When I joined the civilian world, first as an EMT, then as a nursing assistant, it was nothing but red tape. I went from doing assisting, sometimes performing vasectomy, to not being allowed to pack a wound on a general surgery floor. As an EMT, I was regularly given guidance not to do X, Y, or Z because it could put my licensure at risk. In the Army, you do whatever you have to save and care for your patient. So the more medical experience you have in the broad sense, the more prepared you can be. In the civilian world, everyone has their role, and being able to perform beyond your role can easily be considered a hazard. I'm not in medicine anymore, lol. Story 31, as a reservist, I practice in both areas. The primary difference in civilian medicine, my patient always comes first. In military medicine, especially when you're in a combat zone, 3 times the mission always comes first. That is why we often send soldiers back to duty, even when they are not 100. My civilian friends are often aghast at this, but I remind them that we are not conducting a scout jamboree over there, but are fighting a war that often requires servicemen and women to sacrifice their health, and sometimes their lives. Keep that in mind that the next time our country makes the decision to go to send us to fight. Story 32, former corpsman. I found that the destructive behaviors found in the typical military age group, basically boots at 18 to 19 all the way to short timers at 38 to 45. Smoking is incredibly common. Binge drinking puts college frats to shame. And of the active duty suicide attempts, a surprising few were related to what you would expect: combat fatigue, PTSD, etc. If I were to make a graph, depressed because stripper girlfriend was another sailor marine would have to be its own category and would be well represented alongside, but my high school girlfriend swore shed weight. Shouldn't really be surprising. You enlist, and you get a quick break from your entire support structure. You go to college, and mom and dad are there to bail you out. The military also thrives on recruiting people with shitty home situations. Story 33, Army medic, and now civilian nurse. Scope of practice is a big one. In military medicine, for the most part, you can do what you know how to do, so the scope gets pretty wide if you put work in and learn stuff. In civilian medicine, your scope is pretty strictly what your license certifications are. As an Army medic, I could and did do IVs, intubation, NG tubes, push all sorts of 4 drugs, etc. In civilian medicine, a ton of that is paramedic or even MD level, so you can't touch it unless that's what you are. Story 34, mom having me in the Air Force, saluted the doctor, was in the hospital for weeks with preeclampsia and still had to get up every day and make her bed. Me nurses, mom having my sister after the Air Force, everything done for her. No making the bed. Nurses were nicer. Story 35, I wasn't a real doctor. I was trained as a combat lifesaver, which is essentially the guy that keeps you alive until the corpsman can get to you, who keeps you alive properly until you get to the doctor. One of the differences in civilian medicine we were taught is that in most situations we would be in, we ignored the possibility of spine injuries and dragged the casualty to a safe spot regardless of the risk of paralysis, because death was a worse outcome. All of our training had nothing to do with healing and was all about keeping the casualty alive. Story 36, in the civilian world, I can barely give aspirin. In the military, I'm able to give ketamine, fentanyl, and morphine. Not to mention the way we approach patient assessment is completely different. In the civilian world, I can barely even put in an NPA tube that goes into someone's nose to keep the airway open, but in the military, if you have THR right indications, I can perform surgical cricothyrotomy, cutting open someone's throat so they can breathe at my level. In the civilian world, vascular access is a no-go, but it's one of the first things we do in the military side. Also, could never do an IO as a civilian, contrary to civilian medicine. When you take fire, instead of retreating to safety, you return fire. One of the most effective treatments in TCCC is fire superiority in the civilian side. You can almost always do your assessment at the point of injury. The only thing we do at the point of injury or the X is hasty high and tight tourniquets. Everything else waits until we get behind cover or somewhere we aren't taking accurate fire. Edit sauce, am combat medic. Story 37. I've given IVs, sutures, removed moles, removed cysts, etc., without a doctor even being in the room. Some doctors won't even let their nurses do sutures in civilian life. At least a quarter of my patients just wanted to get out of training that day, and probably didn't need to see a medical professional, whereas most people only see a doctor if they're actually sick in civilian life. Trauma, trauma, trauma. Your primary focus is trauma. In civilian life, most daily doctors deal with infections. If you're treating infantry, you need to face the fact there's a very good chance of what you think is an ailment is just a byproduct of steroid abuse. People who cycle correctly don't tend to have the problems, but most military people don't cycle properly. In civilian medicine, your average doctor will never see this. I can't tell you how many cysts and masses I saw removed because someone had a bad injection site. Need meds? Go see a doctor and hope he gives you a prescription. Need meds in the military? Ask your corpsman or medic. If he doesn't have them, he asks his battalion surgeon, who will prescribe thousands of them, and let the corpsman give them out like candy. Anyone who thinks this isn't true, maybe your doctors didn't do this, ours did, want to see a psychiatrist, just call one and make an appointment. In the military, see a corpsman who sees the doctor, who refers you, and then you get the appointment you're given and are happy with it. Your doctor flirts with you and you like him or her. Ask him or her out. One of my good friends is married to a doctor who treated him for an illness. In the military, she's an officer and you're enlisted, and you have to risk either her reporting it to your commanding officer or her saying yes, and you having to keep it secret. When it's time to re-enlist, you have to either keep it a secret or marry her and not re-enlist. Need to do continuing education. Good luck during your 6-month deployment where internet isn't even always guaranteed. Need to go to physical therapy. Boot. If it can't be found by an x-ray, you might go a year before getting the MRI, because no one thinks, geez, maybe it's something to do with his spine and not his shoulder. Even thought 20 x-rays have shown nothing wrong with his shoulder. Can your doctor come to your room and treat you in civilian life? Because a military doctor sure will. Doctors either become doctors because they care about people or because they want to make money. Military doctors join the military, mostly so they can get their degree paid for, not because they care about the military that much. But many do care. The amount who care on the outside is higher, though. In normal hospitals, you have trauma, surgery, ER, or radiology, etc. In battalion aid stations, every medical person, there's all of them, a doctor or corpsman, can be checking for an STD in one moment and checking for a pulse the next. We had battalion runs, and with us giving N4 to someone dehydrated, to giving CPR to a 24-year-old man in great physical condition who is dying. And because you get equipment the AD doesn't even work, the scope of practice for non-doctor medical folks. As a civilian, I am only an EMTB, barely qualified to drive an ambulance. As an Army medic, I have assisted in chest tube insertion and removal, emergency trauma surgeries. I can carry and administer major narcotics, and basically anything that my medical practitioner says I could do. The ability to operate fairly independently in the field is something you want to see as much outside of the military. Story 38, I worked labor and delivery early in my Navy corpsman career. Now that I'm out, I am no longer in medicine. So this will be a bit more of what I've heard about the civilian world of labor and delivery. But I've seen posts about people getting charged for skin-to-skin contact after birth and other ridiculous things. In the Navy, as long as everything was okay, we encouraged it. I also really focused on getting the dad involved and making it a great experience memory. For example, helping me clean the newborn, getting prints, showing him how to make a newborn burrito, etc. To me, it seems that we had a lot more freedom. In the civilian world, it seems that there are price tags attached to everything. If you work civilian labor and delivery, let me know if I'm wrong. Another thing I've experienced, and I imagine is not acceptable in the civilian world, is how we get to practice. It wasn't uncommon to find a room full of corpsmen practicing IVs or blood draws randomly. Docs and nurses also let us try things that were probably a bit outside our scope, which was always awesome and helped us become more well-rounded. I think the military patients we have also makes it easier to be allowed to practice and learn. Very rarely did I bring a new guy in and have a patient lose their mind and demand someone more experienced. More often than not, they either encouraged the trainee or teased them with me, as they were nervously trying to find a vein. Story 39, dislocated arm. Do 3 weeks of physical therapy before we will even think about giving an x-ray. I have seen this policy to chronic complainers ruin people I have served with. No x-ray until after point completion. Story 40, Special Forces medic here. Treating teammates and other SF soldiers was a cakewalk as they were perfect health and highly physically conditioned. You simply treated the injury or illness with too much worry regarding underlying conditions. Treating the indigenous was a different story, even compared to treating civilians in the States. My most significant indigenous experience, in terms of medicine, was immediately following DS-1. During an operation known as Provide Comfort in April-June of 1991, I deployed with my team into northern Iraq, what is now known as Kurdistan, and treated the Kurdish refugees. The situation was dire with lack of clean water, and their physical condition was abysmal, particularly pediatric females. Female babies are of less value in Arab society, and the parents ensured that the male children ate before the females. It was not uncommon to see a fat male baby while his sister was obviously malnourished. As had been mentioned, medical requests for supplies are rarely denied and are always timely. Once I arrived on the ground and assessed the situation, I requested a NATO Warstock 10-bed hospital, which consisted of everything needed in terms of supplies and meds to treat 10 PTs at a time, including tents to house everyone. I identified Kurdish English speakers and was also lucky to have a nurse in my camp, so I made her my assistant. I suppose my lasting memory from that experience was the lack of pediatric meds and supplies. I lost a number of babies to secondary dehydration for lack of PED-4 sets and OS sticks. Sad, and I understand now that these emergency deployable supplies now contain PED and OBGYN supplies. Story 41. I've been in the Air Force for 12 years, still active duty. In my career, I've seen both military and civilian doctors. The biggest difference I've found is that when it comes to military doctors is military first, your health second. When I've gone to the doctors on base, it seems like their first instinct is to think you're lying. They get a lot of people who come in looking for a day off or a waiver on their PT test, so that kind of makes sense. They're less likely to order tests for you or send you off base. I've seen people go in for a torn tendon and be told to rest it and come back in a few weeks if it doesn't get better. One guy I work with went in routinely for 2 years due to leg pain. They kept sending him to physical therapy, saying he had shin splints. Finally, after 2 years, he threatened to go to patient advocacy, and they sent him to a civilian specialist. Turns out he needed surgery, and the issue was life-threatening. Long story short, it seems like the military doctors have the military's best interest at heart, whereas most civilian doctors have your best interest at heart, if you have insurance, of course. Mental health has also come a long way in the military, but is still far behind the civilian sector. After service-related trauma, it took them 1.5 years to diagnose me with something. No one I saw was willing to give me an actual diagnosis, even though I had severe depression, anxiety, and suicidal ideation. It took seeing a civilian doctor to actually get a diagnosis and an actual treatment plan. TLDR, military docs assume you are lying. Be prepared to endure your injury until they decide that you're probably telling the truth. Military comes first, your health second. Military docs avoid giving diagnosis and off-base referrals. These are all my personal opinions and based on my experiences in the military.